a 55-year-old man who is presenting with fatigue.
Madalena, it's kind of doing it again. Sounds like it's going through like a bit of a voice transformer.
Gosh, can you hear me now?
That's great.
Okay, sorry about that.
No, you're all good. It's all
okay,
good.
we will try again. And just let me know if my audio.
Yasmin, your screen looks great.
Got it. The chief concern is fatigue, and this is the case of a 55-year-old man with fatigue. He reports 4 months of progressive fatigue, no fevers, chills, or weight loss, and really no other complaints. He has no past medical, surgical, or family history. He's currently living in Wyoming, no recent sexual activity. In terms of social history that's reported, there's some alcohol use, but no drug use, and does not take any medication or supplements. And that's what it's outlined.
All right. So it sounds like a predominant clinical syndrome is fatigue here. Madalena, I was able to hear most of that. It does sound like you're just a little bit far away from the microphone, but we will roll with it because what I heard was fatigue and no other localizing symptoms for the last 4 months. All right. So, I will say fatigue, rather than taking us through a formal schema here, I will be honest with you that fatigue is one of the most challenging initial chief concerns to think through because it can be caused by anything from a cold to cancer. However, we can make some progress if we translate the fatigue into some other sort of known clinical problems that we see very, very frequently. And oftentimes I sort of will abstract fatigue as one of the possible markers for potentially underlying systemic inflammation. Give me 1 second. All right. And so we have to ask ourselves, could this fatigue potentially represent an underlying systemic inflammatory symptom? Right? That's just not one of the classic symptoms that we may see, right? We usually think about fevers, chills, weight loss, but certainly fatigue and malaise can be in that bucket. Other things that I think about when we think about fatigue, it's going to be things like anemia or bloodstream abnormalities, and then potentially nutritional deficiencies. But to be totally honest, I think it's very difficult to make progress with fatigue alone. So where the bulk of my cognitive energy would be invested in this case is not thinking through the categories that could cause fatigue, but to try to better discover what company this fatigue keeps, right? Because fatigue plus cough and sputum production is going to send us down a much different pathway than fatigue plus abdominal pain and diarrhea than it would fatigue, rash, and joint pains, right? So I think at this point, I would go on the hunt for other associated symptoms that could help us localize either an organ or an underlying bodily system that could be coming with the fatigue here. Because again, fatigue on its own is far too big. And usually it's the company that the fatigue keeps that gives us more diagnostic value. What we do have that is helpful here is the time course here, right? If we usually think about things that last for sort of months, more indolent subacute processes, that can be a helpful way of sort of framing the case once we have a better sense of what the company that it keeps is. But I think at this point in time, that's really where I would be investing both my discussion with the patient as well as the physical exam to try to figure out what else is coming with this fatigue so that we can make a little bit more localizing progress here.
All right, amazing how much teaching points you gave just with a little bit of data and with my poor audio. So I'm sorry about that, but hopefully this is a little bit better. All right, so I'm actually going to jump into the exam findings because a lot of the case here is in kind of the hospital course. So in terms of the exam and the vital signs, so the temperature is 37.2, the heart rate is 90, the blood pressure is 110/60, respiratory rate 16, and the patient is satting 98% without supplemental oxygen. In terms of the physical exam, the patient in general is in no acute distress. HEENT, moist mucous membranes, no scleral icterus. There is conjunctival pallor, no petechiae. Cardiovascular regular rate and rhythm, 2 out of 5 holosystolic murmur at the right upper sternal border, no jugular venous distension. The abdomen is soft, non-tender, non-distended with no rebound or guarding. And for the extremities, there's 1+ pitting edema to the bilateral lower extremities. And I'll actually give some initial labs just for the sake of time, because I know it's a half-hour VMR. So for the CBC, the hemoglobin was 11.5. The remainder of the CBC is normal. The CMP is normal. The ferritin is less than 10, and a TSH is 1.8. And I will pause there.
All right. Well, this is an excellent start here. And I will say, right, we got what we were looking for. We now have a better understanding of the company that this fatigue is keeping. And I think there's 2 predominant findings here that that sort of represent the friends that are joining the fatigue. One of them is the conjunctival pallor, anemia, and what seems to be impressive iron deficiency that we're dealing with here. And then the second one is sort of a bit of a signature of potentially an underlying cardiac disease process. I say that because of 2 things. We have the presence of the murmur and some trace pitting edema in the bilateral lower extremities. But I think if we think about which of these are the brightest lights in this patient's clinical presentation here, the brightest lights is the iron deficiency and the conjunctival pallor, whereas the cardiac signature is not quite shining as brightly. For example, we don't have many of the other classic findings of decompensated heart failure, like elevated jugular venous pressures, crackles on exam, and things like that, right? But the murmur and the pitting edema is something that I'm tracking, but not necessarily focusing on at this point in time. Where I think we can direct our energy is to this anemia and the pretty impressive iron deficiency with a ferritin less than 10. The first thing whenever we're trying to link a symptom with a potential cause is to ask ourselves, can this individual symptom be explained by this potential cause, right? In other words, can iron deficiency anemia cause fatigue? And the answer to that is certainly yes. Now that we see that there is this degree of severe iron deficiency, we have to ask ourselves, well, what could potentially be driving that iron deficiency? And I would say iron deficiency usually comes down to 2 primary buckets, right? One of them, the most common, is going to be a blood loss anemia. For example, individuals losing blood from their GI tract, the most common being chronic sort of slow GI bleeds. There also could be a problem with lack of iron intake, although it takes very, very low iron intake over a very, very long period of time. And so usually nutritional intake is a modifying factor that can accelerate the development of iron deficiency, but not always necessarily the direct primary cause. So with the ferritin less than 10, the indolent progression of fatigue, the hemoglobin of 11.5, right, we would say that this gentleman has symptomatic iron deficiency anemia, and we're going to look for sources of blood loss. And the first place we look is through the GI tract, usually with a colonoscopy and potentially an upper endoscopy. I will say one other thing just related to that cardiac signature that's worth tracking in the background is we said at the beginning that this individual has some sort of indolent fatigue, as well as some symptoms that may be related to cardiac dysfunction, given the pitting edema and the murmur. And whenever you see inflammation plus heart failure together, I want you all to always at least query the possibility of an underlying endocarditis, not because it's necessarily the most common, but because it forces us to ask ourselves, would it be worth sending blood cultures here as well? Which is oftentimes a test that, at least for me, I've forgotten to send in the emergency room a number of times. And so for me, this is me forcing myself to try to remember something that I've overlooked several times in the past. So again, that's something that I'm tracking. Would this be someone where it would be worth sending blood cultures, given that there's this murmur, if it's potentially new, if there are signs of heart failure and this possible inflammatory syndrome that's been brewing, to at least keep that in the background. But again, the focus is going to be on the iron deficiency anemia, but I might also send those blood cultures up front just to see if that potentially gives us an answer as we work towards understanding the iron deficiency anemia.
All right, fantastic. So in terms of follow-up, so over the next 6 months, the patient underwent an EGD, a capsule endoscopy, a CT scan, and a Meckel scan. None of those tests revealed a definitive etiology of iron deficiency. So despite PO iron supplementation, his hemoglobin declined to 8, and he was initiated on IV iron infusions. I'll also give a little bit more information here. So 3 months later, the patient developed melena, prompting admission to the hospital. And labs on this subsequent presentation revealed a hemoglobin of 5. The remainder of the CBC was normal. The CMP was also normal. The PT was 13.5 seconds, INR 1.1. The PTT was not done. And I will pause there.
All right, so we have now found ourselves in the problem space of what sounds like progressive occult GI bleeding with now the development of new melena, right? And so far the workup for this has been incredibly thorough and very well done, right? We've looked at every part of the GI tract. We had the upper tract with the EGD. We had the sort of forgotten space of the small intestine, which we were able to at least take as good of a look as possible with the capsule endoscopy. And then we had the lower tract with the colonoscopy. But yet, despite the negative findings on endoscopy and iron supplementation, this individual continues to have progressive anemia. And when I see something like this, which is progressive anemia despite iron therapy, there's two things that come to mind. Is one, the blood loss is happening and we just haven't been able to see it, right? EGDs and colonoscopies, while great tests, can still be imperfect, and we may miss bleeds or sources of bleeds on endoscopies and colos, especially if the bleeds aren't active at that given time. But while the EGD and colos are great tests, although somewhat imperfect, the capsule endoscopy is notoriously an insensitive test because what you're relying on is a pill to be spiraling through someone's small intestine and hopefully get a picture of a potential source of bleed as it moves through the intestine. And so you can imagine if I asked you all to walk down the street and spin in circles and take pictures, you're probably not going to get a perfect 360-degree view of the surrounding landscape, right? And that is sort of where the capsule endoscopy can be very specific, right? If we see something, it's helpful, but if we don't see something, it doesn't necessarily rule out a source of an underlying GI bleed. And so then the question becomes, well, where could this bleed be? And again, given that the EGD and colo didn't reveal a clear source, and we're having occult difficult to detect bleeding, the possibility of a sort of small bowel or intestinal or small bowel bleed goes up by virtue of the fact that the capsule endoscopy is a relatively imperfect test compared to the EGD and the colo. The other thing is that this is where the murmur comes back into play here. And the reason that the murmur comes back into play is that there is a disease process called Haiti Syndrome that you all may have heard of in the past, which is related to aortic stenosis, causing basically an acquired von Willebrand factor deficiency as these von Willebrand factor gets sheared across the patient's aortic valve. This is usually associated with intestinal arteriovenous malformations and an increased risk of occult bleed. And so at this point in time, right, this individual is coming in now with signs of a frank upper GI bleed with a hemoglobin of 5 and signs of melena on exam. So we're gonna run our usual GI bleed playbook, 2 large bore IVs, type and screen, IV, PPI, BID, and talk to GI. But at this point in time, where I think we're gonna potentially end up is saying the EGD is negative again. How are we going to get a better understanding of where this bleed could be coming from? And again, these AVMs are notoriously bleeds that come and go. And so we may miss them when there's not an active bleed in process, right? This is the challenge of episodic disorders. And so again, we're going to look for upper sources of a GI bleed, but also think about how we can take the best view of a potential bleed within the small intestine in the spaces that the EGD can't quite get to. So this may involve a repeat capsule endoscopy this admission, or it may involve a tagged RBC scan to look to see if we can find the source of a small bowel bleed. And then in parallel, we may want to get an echo to see if this is actually potentially severe aortic stenosis, which would further support the hypothesis of the possibility of Haiti syndrome here.
Wow, a lot of the workup you just recommended kind of mirrors what is described in this case. So in terms of the rest of this hospital course, so the EGD was again unrevealing. A tagged red blood cell scan was done with evidence of small bowel bleed, but subsequent angiography was negative. Balloon enteroscopy revealed jejunal arteriovenous malformation treated with cautery. The patient was subsequently discharged from the hospital. On discharge follow-up, the patient mentioned that the melena continued to recur, requiring multiple admissions. Eventually, the patient underwent laparoscopic assisted small bowel enteroscopy, which revealed multiple angiodysplastic lesions in the jejunum and ileum. The patient was treated with argon plasma coagulation. Given the frequent need for intervention, additional workup was obtained prior to pursuing surgery. So the last bit of information, I guess I'll give after you kind of comment on this, are some more labs, but I did want to mention that a transthoracic echocardiogram was done, which showed a normal EF and no valvular abnormalities.
Ooh, all right. Well, so now I think pivoting away from the possibility of valvular disease, we sort of can focus our evaluation here really on understanding what could potentially be the underlying etiology of this profound and diffuse angiodysplasia within the GI tract. I'll be totally transparent with the group here. This is the point where if I was taking care of this patient, I would have a hard time advancing this reasoning process forward without talking to consultants or talking to experts here, right? Diffuse angiodysplasia, or AVMs, is a disease that I'm aware of, but the underlying etiologies is not a framework nor a schema that I necessarily have a systematic approach to. There are some word associations that I have, but I want to be able to give the group a more reasoned and thought out approach. So I'm actually going to say, Madalena, I'm going to turn it back over to you all and take with me to the bank from this case the fact that I've reached sort of what feels like the edges of my reasoning process in terms of thinking about what else could cause the underlying angiodysplasia. I suspect that there's hereditary disease processes that do it. Again, Haiti syndrome is the most common acquired cause that can do it, or not the most common, but is one of the acquired causes that I think about here. And so I'm super excited to learn sort of from you and from this case what else could cause such diffuse angiodysplastic disease like this. Because yeah, I think that is a schema that I'm excited to get to build for myself going forward.
Yeah, no, definitely. And I really appreciate your kind of the authenticity of how you're walking through this case. So there's a series of labs that I'll give, and then the last bit is just kind of the case resolution. So in terms of labs, factor VIII activity was measured, which was 11%, which is low. The normal says here between 51 and 166%. The von Willebrand antigen was less than 10%, which is low, normal being 49 to 163. The von Willebrand factor ristocetin cofactor was less than 12%, also low. Von Willebrand factor multimers, so this showed the absence of high and intermediate molecular weight multimers. And then a von Willebrand factor propeptide antigen was 292, which is high, the normal being 56 to 140. And the rest here is I have some information about the case resolution. Jack, did you want to comment on this at all?
No, please take us home.
All right. So during his clinical course, a serum electrophoresis with immunofixation was performed, which revealed a 0.2 IgG lambda monoclonal protein. So the patient, it seems like the working diagnosis here was acquired von Willebrand syndrome. And this was treated with IVIG, leading to rapid improvement in his von Willebrand factor measurements within hours. He was discharged to the care of a hematologist for completion of workup for his monoclonal gammopathy and consideration of treatment. He is also to be continued on IVIG infusions every 3 weeks. 6 months post-discharge, he had no further melena, and his hemoglobin had returned to normal.
Absolutely incredible case. This is awesome. To me, this captures like what is the joy of the VMR space so much, right? The discussion in the chat was awesome. It's an incredibly interesting case. I always talk about the purpose of case conferences is to find the edges of our knowledge and get to take them one step further. And I just feel so happy and grateful to have gotten to do that with this amazing supportive community. And I want to give a shout out to Joseph, who said von Willebrand disease a few minutes ago. Joseph, if you're in a place where you're able to unmute, would love to hear from you about what tipped you off to von Willebrand disease when some of those initial studies about the angiodysplasia came back. And Joseph, no worries at all if you're not. Oh, great. Joseph, we're having a bit of a hard time hearing you. But the group is shouting you out that you've been on fire. Well, Joseph, I hope you're feeling the support from us. And again, just a great call there on the DDX. I'm going to turn it over back to Shema to take us through some of the teaching points for this case. But I just want to say again, thanks again for the group, and I'm excited to dig in more into other causes of acquired von Willebrand disease. But yeah, this was a ton of fun. Thank you, Madalena, for bringing this case.
So, hello everyone, and thank you, Madalena, for this amazing case. I will just try to go through some quick teaching points. So first of all, we had the chief complaint of fatigue, and we learned from Jack to consider it could be due to a systemic inflammation. Also think that this could be a symptom due to underlying malignancy, infections. Also think that anemia and nutritional deficiencies can cause fatigue. And the main important feature that we also learn is to be aware of the associated symptoms. Like if you have cough, to see where the center of gravity is, that leads you to the cause of the fatigue. And also the time course is very important. And then we try to approach iron deficiency anemia, which is the most common cause of anemia worldwide. And the most common causes for it are blood loss, especially a chronic slow bleeding in the GI tract, like colorectal cancer, or the lack of intake. And as we learned, anemia can show up with fatigue, and especially if the anemia is acute, we usually also see some signs of compensatory tachycardia. If it's chronic anemia, usually we don't see tachycardia because it is actually already compensated. And the workup for GI bleed, as we learned, usually we start with a colonoscopy and EGD. And in order to detect bleeding in the small intestine, we also do the capsule endoscopy, but we learned that this is an insensitive test. And it doesn't necessarily rule out GI bleeding. So you can also perform a tagged RBC scan, which was done in this case. And then we also learned about progressive anemia despite iron intake. Then be aware that there could be some blood loss. Also think of anemia of chronic disease where you have impaired iron resorption due to high hepcidin levels. And also think of malabsorption, like I would say like in inflammatory bowel diseases. And then we were talking also about Haiti Syndrome, which is basically a form of an acquired von Willebrand syndrome due to aortic stenosis, because the aortic stenosis leads to a shear stress, and therefore we have a von Willebrand deficiency, and this is also associated with intestinal AV malformation. So we have a high risk for occult bleeding. And yeah, that's everything. Thank you so much.
Amazing, Shema. Jack just messaged me saying that he was going back down to the ED, so just wanted to close it up here. But thank you everyone for tuning in. Apologies for kind of the difficulties in my in like being able to hear me at the beginning, but so much learning even in just a half an hour. So nice to see you all, and hopefully see you at the next VMR. Bye, everyone.